Okay, so I'm going to try this on the lowest resolution to see if that helps. So, hello everybody. Oh wait, let me get the position. Hello everybody. Mostly hello Dennis. This is my AEMT Supraglottic Airway skill video. Take 3. So I've got all this stuff. Got some OPAs, a King, number 4, colorimetric CO2 detector, syringe, mask, bag valve, commercial securing device for the airway, supraglottic, my stethoscope for oscillating the epigastrum and 4 quadrants of the lungs to make sure I have a proper placement of the airway. And another CO2 capnography attachment for my cardiac monitor, some lubricant. Here's our patient. Hi there. I'm guessing he's about 5'10" to 6 feet. So I've selected the number 4, King. I think, yeah. I forgot my gloves, but I'm just going to vocalize that. But so let's get started. All right. PPE for BSI. Is the scene safe? Got my gloves on, got my mask on, got my goggles, got my face shield, got my hat, got my gun, got my booties, and I'm wrapped with saran wrap. So, hello there, sir. Can you hear me? I don't hear any breath. I don't see anything. I've got less than 30 seconds before starting this to adjust the airway and size my airway. Lift the tongue a little bit and place it, and then forgot. And let's see if we can. No. Oh, I'm getting some chest rise, I think. Yeah, we got chest rise. Gotta do every 5 to 6 seconds of breath. Try goal is 10 to 12 per minute. When I put in the airway, I heard from my examiner that there was no gag reflex present, so that's good. Now, as I'm ventilating, I hear from the examiner that we have oxygen saturation of only 85%. So that's not good. We're gonna need to hook up some oxygen. So I'm gonna hook up oxygen to the bag valve at 10 to 15, but I'll use 15. Okay, and I got oxygen, rich, high flow, high concentration going into my patient's lungs. That should bring up the pulse ox readings, hopefully. So now, next I hear from my instructor that, my instructor auscultates the chest, hears bilateral chest breath sounds, and informs me that Online Medical Control has ordered a supraglottic airway. So I'm going to pass this over to my instructor, my examiner, invisible here, who's going to continue with the breathing for me to pre-oxygenate the patient while I inspect my equipment. So I'm going to choose the number 4 for a 5 to 6 foot tall patient. Takes 60 to 80 milliliters of air. This will give me 65 all the way out, I think. I think I'm putting in a little bit more. And no leaks, no cracks. Looks like it's in good shape. All right, let's evacuate this. So if you fold the pilot tube, the pilot bulb, you can make your own little seal. There we go. Lubricate. Make sure my partner is still adequately pre-oxygenating my patient. I'm going to instruct my examiner to, at the end of the next breath, remove the bag valve mask and I'll take out the OPA and get out of my way, please. So this is happening. Bag valve mask is removed. I'm going to remove that and then quickly do a jaw. Should have prepared that tongue lift. And suit this up. Just nice, just like that. Ooh, nice and easy. Make sure it's at the proper depth. Yeah. I think that's good. Let's see, let's try some air. Oh yeah, seems to seat. Touch more. Now remove the syringe immediately and resume. Oh yeah, we've got a good one. Let's see if there's any leakage. No, I don't feel any leakage through the oral cavity. Oh, great response though from the both lungs are working now. I thought maybe the guy had a pneumothorax, but so that is excellent. Now I'm going to ask my partner examiner to take over the breathing again and make sure that the king airway is not dislodged. It stays secure, stays stable. Be careful when moving the bag. All right, so now my partner is taken over. I'm going to auscultate the 4 quadrants of the lungs for equal breath sounds, and then the epigastrum to make sure there's nothing going into the stomach. Here's that. Sounds good. A little below, just below the sternum, epigastric area. No sound. I'm going to go inside the patient because there's no thing stopping me. I have no sounds that need to adjust the airway. I've got good placement and breath sounds. So now to verify, to double check, I will use capnography to be certain that that this is effectively ventilating the patient. There. Making sure not to move or dislodge the airway. This will hook up to my monitor. Sure was effective, this king airway. Makes a really good effective seal. And so I'm looking for a 35. Well, a normal person who's adequately perfusing and doing the gas exchange in the lungs, the respirations, will have 35 to 45 millimeters of mercury worth of carbon dioxide leaving their lungs at the end of each tide. So I'm looking for a nice waveform, not a sharp tooth, and that looks good. With the colorimetric CO2 detector, gold is golden. You want to go there if you can. Purple is not. It's bad. Means you're not doing well. So I'm going to ask my partner to take over the breathing again while I secure the airway. All right, partner, please take that. No, not like this. No. All right, I believe my examiner might ask me, how would you know if you're getting adequate volume on your ventilations? I would say, look for chest rise, or in this case, lung movement, lung expansion. I believe I have completed this skill assessment. Okay, thank you.